Welcome all of you to this live program at Orthopedic Principles. Today our guest of honor is Dr. Pierluigi DiFelice from Balearic Island, Spain. Dr. Arden is consultant orthopedic surgeon specialized in shoulder and elbow surgery. He's founder of the Manresa Shoulder Unit in Altaya Hospital and has a special focus on athletes and sports-related injuries. He has extensive experience in the use of 3D design and printing technology with publication of scientific papers in well-recognized international journals. And he's one of the chairs of the orthopedic departments at Policlínica Miramar Joaneda in Spain. So today it's my great honor to introduce you to Dr. Pierluigi DiFelice from Spain. Over to you, Pierluigi.
Yes, thanks so much, Hitesh. It's a pleasure for me to be here. Today we will talk about distal humerus fractures. We will analyze current concept and especially focus on the plating system review. So we will talk about also biomechanical principles of these kind of fractures. And finally, we will see some clinical case that would be very, very interesting. So let's start with that. About the introduction, we have to see that about the incidence, this kind of fracture represent about 2% of all the fractures and around 30% of all the humerus fracture. They have a bimodal distribution, especially with high energy trauma related with the young males, or also in the elderly people in falls or low energy trauma. It's important also to remember that due to this complex geometry, we have to divide this fracture into articular and the extra-articular fracture. So the AO classification help us with that. We can see that there are basically three groups. The extra-articular fractures and the articular ones that could be also divided in partial and complete. And each one of them are divided into subgroups depending of the fragments and of the location of the fractures. So in my opinion, the double reclassification is also very useful because it allows us to divide the fractures that involve the capitellum with or without the trochlea. So in this sense, we can see some surgical image by my friend and colleague, Dr. Antunia, where we can observe some pattern fracture around capitellum and trochlea. When we talk about the geometry of distal humerus, we can see that it could be represented by a triangle. And basically, we can distinguish here a medial and a lateral column, and the trochlea acts as a tie arc, if we can see as an architectural point of view. So in this sense, it's very important when we think about fracture at this level that we remember two principles. The first, that we have to maximize the fixation of these distal fragments with screws. And then we have to guarantee the stability in the supracondylar navel. For this reason, it's also very important the concept of the interfragmentary compression in the supracondylar navel that we can see very well in these two images. So what about the surgery? What about the fixation principles? So basically, we have to think that the exposure is so important in this kind of fractures. So we have to use the approach we are more comfortable with to solve these difficult fractures. We have to manage nerves, especially with the ulnar nerves in the distal navel, and in more proximal fracture, we have to manage also with the radial nerve. And also important to remember that we have to allow early mobilization of the surgery, so to recover all the mobility after that. About the surgical positioning, in my experience, I prefer to use a lateral decubitus with the arm positioned on an arm holder. normally I don't use any tourniquet because when I want to extend my approach proximally, I prefer to have more space and no problem with that. So in my experience, I never use tourniquet. What about the approaches? About the surgical approaches, they are basically divided into three main groups. The first one that are the triceps sparing group, and then the splitting triceps and the olecranon osteotomy. We can see in this slide the organization of these kind of approaches. And now we will analyze the most important ones and the ones that I use in my practice. About the triceps sparing approaches, we can see the Alonso Yames. It is a very, very nice approach because we are able to create two windows, a medial one where we can see the ulnar nerve and the lateral one without the triceps. So in this sense, we have the preservation of the extensor system and the fast recovery. But we have also to remember that when we have a very comminuted fracture in the articular surface, it doesn't allow to see 100% of the articular surface of the humerus. Another approach that we can use in this kind of fracture is the Campbell. In the Campbell, we do a central incision on the triceps, and in this sense, it allows to see perfectly the posterior side of the humerus, but we have to take care, especially when we close, because it's important to remember that the triceps insertion should be repaired to the olecranon with a transosseous suture. So it's a very important step when we finish the surgery. Another approach, this is an example of the Campbell. We can see in this case the comminuted fracture in the distal humerus that we fix with the tube plate in the orthogonal way, 1990, and the result was very good in this sense. So another approach is the Brian-Murray. Brian-Murray approach is primarily used for elbow arthroplasty, but can also be used in distal humerus fractures. Probably the disadvantage to use this approach is the need to repair and protect the triceps during all the procedure. We can see also that in this approach, triceps and anconeus are elevated as one flap, just to expose all the distal humerus surface. So what about the literature? If we see this paper, we can see that the olecranon osteotomy and the paraticidal approaches for the intraarticular fracture of the distal humerus normally have the same result when we talk about the AO 13C1 and C2, but in the C3 type, probably it's convenient to use the olecranon osteotomy because it allows to see so much better the articular surface and to manage these fragments in a better way. We can see here another anatomical details of the olecranon approach. Normally what we do is to elevate with an osteotome the olecranon in a chevron osteotomy way and mobilize the ulnar nerve. It's important to remember that normally in the chevron osteotomy, the apex is distal. And at the beginning, it's better to start with an oscillating saw. And then finally, we complete the osteotomy with a manual osteotome. So it's also important to remember in which ways we fix the olecranon at the end of the surgical procedure. So basically, we have three options. The tension band wiring with QRs, the cancellous fixations, and the dorsal plating. In my experience, I really love the fixation with the cancellous partial screw at 6.5 millimeters because it's a very fast process. and it allows a very early mobilization of the elbow. So another concept that we need to analyze when we talk about distal humerus fractures is the configuration of the plates. So we know that in this sense, we can fix these fractures with parallel constructs or with orthogonal constructs. In the literature, there are no big differences between these two ways, but it's true that probably the parallel constructs provide a greater axial stiffness and axial strength when we talk about this fracture. In the last years, many papers were written about this difference between parallel and orthogonal plates, and at the end, the conclusion is that probably the results are similar. So this is an example of an intra-articular fracture with a huge comminution of the distal humerus. You can see by the video that we do an molecular osteotomy, we isolate the ulnar nerve, and in this case, we decide to do a 1990 construct with one posterior lateral plate and one medial plate, and fix the olecranon with the third plate. So in this another case, instead, we prefer to use a parallel construct and fix the olecranon with the tension band wiring. So what about the extra-articular fracture? So till now, we talk about the articular fracture, but we also have to consider the other fracture in the distal humerus that are the extra-articular ones. So in this case, normally, most of this fracture could be solved with the one posterior lateral plate, but we have also to consider a good bone quality and an adequate distal fixation. Normally, when we have comminution or more fragments at this level, I recommend to use a double plating to provide a more rigid fixation. So it's important also to remember that in some cases, we can consider the possibility to use the MIPO technique for the extra-articular fractures. But it's very important also to remember that we can have nerve injury, especially radial nerve injury, and also malunion of the fracture if we don't reduce well the fragments. So let's start with some clinical case. This is a woman, 37 years old, a yoga teacher. She suffered bike accident. We can see from the X-rays comminuted fracture in the distal humerus. In this case, we use a Gerwin approach, and we put a big posterolateral plate that worked very well. This is the result the day after fracture. The woman was without pain, and after 3 months, she returns to her previous activity, and she was able to practice yoga without any problem. And we can see from the X-ray a complete healing of the fracture. Another case, probably the same pattern, a man of 48 years old with distal humeral fracture. We used the same approach, we used the same plate, and the result was also very good. But all of the cases have the same result. Sometimes we can have complications, like in this case. This is the case of a 64 years old woman, smoker, that had a car accident in Italy. She had the first operation in another hospital. So she came to see us in our department with these X-rays. We can see that the fracture is not reduced. The plate was short. So we decided to do a new operation. We remove all the hardware, and we fix the fracture with a long posterolateral plate plus suture sacrilege. The evolution was very good in the first 3 months, but after the 3rd month, she started with pain. and we can see here that the plate broke and the fracture was not healed. So it was a very complex case where we decided to do a new revision. And in this case, we decided to put a longer posterolateral plate with the iliac bone graft. We also studied the possibility of an infection, but all the tests were negative. In this case, the result was good at the beginning. You can see that the mobility was complete in elevation, abduction, some restriction in internal rotation, but the pain, the patient was pain-free. So the first 3 months were very well, but after the third month, the pain starts again with pain. And again, we have the rupture of the plate and so in this case, we have some options to decide what to do. To do a new surgery, fixation with 2 plates, to use an osteochondral vascularized graft, or to do an external fixation. So in this case, we decide to do 1-stage revision, and the surgery was done with the fixation with 2 plates, 1 posterolateral, 1 medial, doing an olecranon osteotomy to see better all the fragments. And we have some radial nerve palsy after surgery, but it solved by itself in 2 months. So actually, these are the last X-rays. 5 months after surgery, we can see that the fracture start finally healing, and the patient is okay. She has not pain. Mobility obviously is not the same than before. It's restricted, but she can use the arm without any restriction, any limitation. So finally, to end this presentation, we have to talk also about another pattern that is very typical in fracture. We're talking about the Holston-Lewis fracture that are very common in people that participate in arm wrestling. Normally, in these kind of fractures, we have the radial nerve trapped between the distal humerus fragments, and we have always a third fragment, a wedge fragment. So they are complicated surgery, but in these cases, we prefer to do an olecranon osteotomy, isolate both the ulnar nerve and the radial nerve proximally, reduce the fragments, and put a double plate in a 1990 configuration. And just to finish the presentation, I want to present the last case with another Holston-Lewis fracture, a woman of 38 years old that fall downstairs. In this case, we opted for another approach that is more indicated in the lateral condyle fractures, but in this case, we decided to use the lateral approach because of the plate that we had at this moment. And we had also a good result with complete healing of the fracture. And we can see from the video the recovery of all the mobility of the arm without any limitation. So thanks so much for your attention. I hope that this presentation was useful to see many concepts about this fracture. And thanks, Heritage, for the invitation. It was a pleasure.
Thank you, Pierluigi. Pierluigi, you can stop sharing.
Yep. Okay. You can
There's an
hear
option.
me?
You can stop sharing. Yeah, you can.
Yeah. Okay. I will. Just 1 second. Okay.
Thank you, Pierluigi, for this nice presentation with a lot of clinical cases and really challenging some of them.
Yeah, I love to present clinical cases because I think that is our daily routine. So many times we have good results, but it's true that sometimes we have to fight against bad cases, very complicated cases, and it's difficult to find a solution.
Pierluigi, let's have a short question answer session.
Sure.
Yeah. Pierluigi, you mentioned so many approaches, like the Campbell's approach, the Alonso Lama's approach, and the approach with an olecranon osteotomy, right? So which one do you prefer in your routine surgical practice? Because I personally, I love to do the olecranon osteotomy because of the exposure, the visualization that it allows.
Yeah, exactly. Normally, when I have an extra-articular fracture, I prefer to use the Alonso Yames approach because I think that we can manage both windows, the medial one from one side, lateral one from the other side, without touch the triceps, and it is very, very useful. But as you said, when we have an articular fracture with many fragments, that is difficult to reduce. So in this case, I prefer to do the olecranon osteotomy and see very well the articular surface, the articular window, and reduce the fragments in this way.
And have you thought about putting a plate for the olecranon osteotomy? You said you use a lot of time the intramedullary screw, right? So have you tried using the plate for the osteotomy?
Sometimes, but in the last years, I prefer to use the cancelled screws because patients refer less pain. In the case of the plate, most of the patients want to retire the plate 1 year after surgery. So in this case, normally in my practice, I used to put or the cancelled screws or the tension wiring. Yeah.
Yeah. And Pierluigi, what about distal humerus fractures in the elderly, intra-articular fractures in the elderly? Do you have an option to do a distal humerus hemiarthroplasty in your center?
Yes, I have. It's another big argument to discuss. I didn't want to touch that in the presentation because it was a bit long. I think that in the elderly population, we have to consider many options treatment because we don't have to forget that also the conservative treatment in this kind of patients could be a good option. As you said, the hemiarthroplasty could be an option when the fracture is impossible to reduce and fix. But in my hands, if I can, I prefer to do an osteosynthesis.
Just one last question before we end the session. Now, in the last case that you showed there's using a lateral approach to the distal fracture, right? Not a postlateral, a pure lateral. So how did you identify the radial nerve? How difficult was it to identify the radial nerve when compared to a standard posterior approach?
Yes, in this case, I decided to do this approach because I was on ward and I didn't have all the plates in that hospital where I was. So I just had a straight plate. So in this case, I prefer to go lateral. That, as I said before, it normally use this approach more for lateral condyle fracture and not for distal humerus fracture. And in this case, you have to take care, especially about the radial nerve. So you have to go very slow in the dissection. Try to identify the nerve, then separate the muscular structure, reduce the fracture, and put the plate.
Thank you, Pierluigi. I think that's all the questions that we have for this session. Thank you for this wonderful presentation, and I'm sure it's going to reach to a lot of people.
Thanks to you.